Hello. I hope everyone has had a good day. Today we're going to continue with the cardiovascular system. Last week we looked at the heart. This week we're going to look at the blood vessels, how the vessels work, and how that contributes to how blood flows through the body, through the heart, through the lungs. It's kind of how it works everywhere. So, what are blood vessels? Well, they're the delivery system. They're the beginning and the end of the heart. Blood vessels also work with our lymphatic system to help circulate fluids around the body. So it's not just our blood vessels getting fluid everywhere, it's also that lymphatic system. Arteries carries blood away from the heart. It's oxygenated in all cases except for that pulmonary circulation. And technically, the umbilical vessels of the fetus are also deoxygenated blood. Everything else is oxygenated. Capillaries. Capillaries is how we get nutrients to the body. They have direct contact with tissues. Things can diffuse in and out of the capillaries to get into those tissues to supply nutrients that are needed. Veins. Veins carry blood towards the heart. In every case except the pulmonary circulation and the umbilicals, it is deoxygenated blood. So if you remember from the heart last week, the heart pumps blood into the pulmonary trunk to the pulmonary arteries that is deoxygenated, goes to the lungs, picks up oxygen, comes back to the heart, where it then goes to be pumped out the rest of the body. So our lymphatic system also carries fluids around the body. The lymphatic system is in green. That lymphatic system will drain into the venous system before it enters the heart. So the heart pumps all fluids from the circulatory system and the lymphatic system around the body. So let's look at what's up blood vessels. They all have a lumen. That lumen is the space where blood flows through. All vessels except capillaries have 3 layers, or they're called tunics. So we get tunica intima, the inside layer, tunica media, middle layer, externa, external layer. So they say exactly where they are located in the blood vessels. Capillaries have an endothelium. Endothelium are those endothelial cells, and they don't have like the whole thing is not covered with a basal lamina because that's where diffusion happens between the capillaries into the tissues. So let's look at what makes up these different walls of blood vessels. That tunica intima is that innermost layer, as I said on the previous slide. It is endothelium. So it's made up of simple squamous epithelium, and that's technically what lines all blood vessels. Some epithelium is actually continuous with the endocardium from the heart, and it provides this nice slick surface so blood can flow through without getting stuck. It doesn't have some kind of friction to it. Underneath that endothelium is a subendothelial layer. That is a connective tissue basement membrane. But that's only found in vessels that are larger than 1 millimeter. We do have vessels smaller than that. We will get to those today. Our tunica media. Media, middle. That is mostly smooth muscle. We'll also have elastin fibers in that tunica media because we need those blood vessel walls to stretch. That tunica media has sympathetic vasomotor nerve fibers because we don't control smooth muscle controlled by our autonomic nervous system. So that autonomic nervous system will either go through vasoconstriction, they constrict smaller, lumen decreases in diameter, so it would get a lot smaller, versus vasodilation, dilate bigger, so that increases that lumen diameter. Tunica media, it's kind of responsible for what maintains blood flow and blood pressure. So that tunica, the smooth muscle, is what will help pump the blood through the vessels throughout the body. Our last layer, the outermost layer, is tunica externa, external for outside. It can also be called the tunica adventitia. Most collagen fibers, those loose collagen fibers, because it could help anchor that blood vessel to a wall, anchor it to something, some structures around it. Those collagen fibers kind of help hold everything together. That just like that tunica media, there's also nerve fibers in that tunica externa. There's also lymphatic vessels in some of those, and some of the vessels of the turn that in that tunica externa. Large veins, also called elastic fibers. We have a lot of elastic fibers that in this layer. We have vasa vasorum in this layer, which is in those really large vessels, like we kind of looked at the aorta specifically. That's a very large vessel. A vasa vasorum supplies blood and nutrients to the tissues that make up that wall, that tunica externa and that tunica media. So some of these larger blood vessels need their own blood supply to work. So that's what the vasa vasorum is blood vessels that's supply nutrients to the outside of these blood vessels. So here we start with an artery on the left. You can see that tunica intima, that layer here of simple squamous endothelium. We get that subendothelial layer that is connective tissue. And we may have, in this example, we have an internal elastic membrane. Then we get the tunica media, middle layer, has smooth muscle and elastic. And then we have the tunica externa. You can see that vasa vasorum. You can see it really well over here. You see little arteries and veins. The yellow is the nerves. These are all supplying this layer of the blood vessel with nutrients. So here's some of the different blood vessels. We can have what are called elastic arteries. Elastic arteries are going to have a lot of elastic fibers in them. That is their main feature. I know they were out when you were in Anatomy 1, but if you ever looked at blood vessels or even like elastic tissue under the microscope, the aorta is an elastic artery because that's usually the one that is shown. And it has a lot of elastic fibers. A muscular artery, as you can see with the picture, there is a thick layer of smooth muscle that makes up muscular arteries. Arterioles. Arterioles are what arteries flow into. They go from arteries, arterioles, then we'll go through some more to capillary networks, and then we'll keep looking at the different sizes. Here are some of the capillaries. In our capillaries, usually a single layer of simple squamous epithelium. There may be some kind of connective tissue type lining on the outside, or there may not be. It all just depends on where the capillaries are and how fast things need to diffuse in and out. Capillaries are the smallest blood vessels we have in our body. On the other side of capillaries, we get into veins or venules. Venules are smaller than veins, just like arterioles are smaller than arteries. So as blood starts flowing back after that capillary network, it'll go into venules. And those venules will then drain into veins, which will continue all the way back to the heart. So let's look at these different kinds of arteries. Elastic arteries. They're very thick walled. So least amount of resistance out of any of the different arteries. As mentioned earlier, the aorta, an elastic artery. And it's also called ducting because it conducts blood flow from the heart to all over the body. Elastic arteries needs to have elastin fiber in it, of course. Most tunica media muscle. It kind of acts as a pressure reserve that'll expand and recoil as blood gets pumped out of the heart. So every time the heart pushes blood into the aorta, that aorta is going to expand. Then it'll come back down before the next pump of the heart. Next pump of the heart will expand the aorta, then it'll come back down to normal size again. And every time blood is pumped out, it's going to change, going to expand and then recoil. Muscular arteries. First, we have that elastic aorta. First, we have that elastic aorta. That elastic aorta drains blood into muscular arteries. Let me switch my internet connection for a minute. As blood is being pumped out of the heart into the aorta. As the aorta pumps blood further into the circulatory system, after that aorta comes muscular arteries. Muscular arteries are also known as distributing arteries because they distribute blood to the organs of the body. They distribute it out to your arms, your legs. Most of the arteries that you need to know the names of on that sheet from lab are muscular arteries, minus the aorta, of course. But from that picture we looked at, muscular arteries have a very thick tunica media, and it doesn't have as much elastic tissue as elastic arteries. Muscular arteries, because there's so much smooth muscle in these arteries, they are very active in vasoconstriction. So they can get smaller. So if this is their normal size, they can constrict down. They can constrict down even further, and they can also release it back up. So they can constrict and dilate. That is what muscular arteries are really good at. After muscular arteries, blood gets pumped next into arterioles. Arterioles are the smallest type of artery. So they're kind of called resistance arteries because they're going to kind of change the flow of blood as they hit the arterioles, because we're going from a really big, like the aorta, to a muscular artery, to an arteriole. So we're going big, small, smaller. So as blood hits these different arterioles, they're going to slow down their flow a little bit. They're going to hit more resistance because the walls of the artery aren't as big. So there's two different kinds of arterioles. There's large arterioles. They still have all three layers, or all three tunics, intima, media, and externa. But the smaller arterioles, they're just kind of a single layer of smooth muscle and endothelial cells. That's it. So as the arterioles go, as they're about to feed into those capillary beds, they get smaller and smaller before they lead to the capillaries. So arterioles are actually what controls that flow into the capillary beds. So they can constrict, get smaller, or they can dilate and get bigger, just depending on how fast blood is flowing, where blood needs to flow. They can change all of that. So our arterioles are what eventually leads to capillaries. In capillaries, these are the smallest type of blood vessel. They are so small that a single red blood cell can pass through at a time. Only one. They go through in like a single file line is the best way to kind of describe it when they go through capillaries. They're just a tunica interna or intima. So we have these cells that are called pericytes. And pericytes will actually stabilize these capillary walls. They determine how permeable that wall is going to be. How much are they going to let out at the capillary bed? How much are they going to keep in the blood in those capillaries pushing through? So capillaries are actually what supply almost every cell in your body. If you remember from the tissues chapter, they do not supply cartilage because cartilage is avascular. They don't supply your epithelia or they don't directly supply your skin because those endothelial layers of your skin are technically avascular. Your skin gets nutrients through diffusion from the dermis, the level below it, the cornea, and the lens of the eye. Those are the places where capillaries do not feed into. So, like in our lungs, capillaries exchange oxygen and carbon dioxide. They will exchange nutrients with our tissues. They'll exchange wastes in our kidneys. They will exchange hormones to different tissues throughout the body. So all of this is going on between blood and interstitial fluid. Things are going back and forth all the time. So all capillaries are joined by tight junctions. The endothelial cells are connected together by these tight junctions. So we'd have one cell, another cell together. And these are all connected by tight junctions through here that prevents too much stuff escaping through. It allows for fluids to pass. It'll allow for some ions to pass, some small things to pass, but something like glucose won't pass through. So we technically have 3 types of capillaries. We have continuous capillaries. These continuous capillaries, they're found in the dermis, just underneath our epidermis. They're found in our muscles. They're found in our lungs and our central nervous system. Our continuous capillaries are what makes the blood-brain barrier. So that keeps the blood and our brain separate. what that blood-brain barrier does. We don't want blood in our cerebrospinal fluid. So this is a continuous capillary. And see, it's just big enough for one red blood cell to get through at a time. We have these tight junctions that help to hold everything together, help hold all the cells together. We also have these pericytes. These kind of also help hold the cells together. We have what are called fenestrated capillaries. This is where we have a lot of filtration happening, like the kidneys. The kidneys do a lot of filtration. Our intestines, they're constantly absorbing nutrients. Or endocrine hormone secretion. They're going to be through fenestrated capillaries because they have, it literally will look like Swiss cheese pores throughout the capillary. Those are called fenestrations because they allow for things to filter in and out of the blood supply very easily. So here's that fenestrated capillary. That fenestrated capillary, as you can see, has lots of holes in it. And that's what helps to let things filter through, either out of the blood in the kidneys or back or into the blood in the intestines. We also have what are called sinusoidal capillaries. They're usually fenestrated, and they have a very incomplete basement membrane. They usually have some pretty large lumens. So those lumens are the area where the red blood cell travels through. They're only found in the liver, bone marrow, spleen, and the adrenal medulla. Blood flow through sinusoidal capillaries are very slow. And this allows for cells to pass between the blood tissue. So could be macrophages that are cleaning out anything that could be carried around in the blood. Could be some kind of bacteria that's in there and your body is trying to clean it up. That's especially in the spleen. It's sinusoidal capillaries are kind of what it's another way for your body to clean your blood, but not of wastes, more of foreign invaders. So sinusoidal capillaries, you can see the fenestrations or holes are a lot larger throughout. Doesn't have a really complete basement membrane because all these holes in here actually allows for macrophages to get in and out, and it allows your immune system to help clean out your blood. So what exactly are capillary beds? A capillary bed is kind of a network of capillaries that are found between arterioles and venules. So on one side, we'd have arteries feeding or arterioles feeding in. We get this whole woven network of capillaries that come through. They turn in the other side of the capillaries here, and they feed into venules. There. So this whole section in the middle here, this is a capillary bed. Through those capillaries, we have what is called microcirculation. Because only one red blood cell at a time can actually get through the capillaries. A terminal arteriole, that is actually an arteriole that'll branch into, mine was only 3, but a terminal arteriole will branch into 10 to 20 capillaries. That's a lot. Those capillaries is where a lot of the exchanges of everything takes place. Those capillaries will drain into what is called a post-capillary venule. From there, the flow is now upstream. We're got to get back to the heart. So here's some examples here. A typical capillary bed, as long as these arterioles are dilated, blood is going to go through this capillary bed from the arteriole through the capillaries to the venule. But these arterioles can also constrict. So it got smaller. And if it's going to constrict blood flow to that area, then blood will not flow through those capillary beds. So those arterioles can control whether blood flows into those capillaries or not. Like when you're exercising, blood flow is directed more towards muscles to keep you moving. Or when you're hot, your blood supply helps with thermoregulation, regulating your body temperature. So those arterioles are going to dilate and send lots of blood through those capillaries because we need to release off heat if it's too hot. They also constrict when it's too cold. Back down to the second picture. It's too cold, a lot of these arterioles will constrict and won't let blood into those capillaries because they're trying to keep your core of your body warm. So there's a lot of different factors that determine when and where blood flow happens. So we have different kinds of capillaries in different places. This is kind of what I was talking about. We have what is called a vascular shunt. And in that vascular shunt, it kind of connects arterioles with venules. It bypasses those capillaries. So sometimes we don't send blood to the capillaries. We send them straight from the arteriole directly to the venule. We have a precapillary sphincter, and that can actually close off blood supply to either part of the capillary bed or all of the capillary bed. It's not controlled by the nervous system. That is controlled by chemical conditions. So here's with a vascular shunt, you can see these sphincters. Here's a precapillary sphincter. These ones are closed, so blood isn't flowing to those capillaries. There's that arteriole goes in directly to that venule. It doesn't hit all the capillary beds around it. It has a meta-arteriole. That meta-arteriole is what carries that blood from that arteriole to that venule without hitting the capillary beds. But these precapillary sphincters over here are open. Since these are open, blood will start to go into some of those capillaries before it hits that venule. So sometimes these sphincters can remain closed and just shunt blood to different areas. Or they can be open and shunt blood to all areas. It all just kind of depends on where blood is needed. So the next part in the system are the veins. Veins' job is to carry blood to the heart. They start at the end of those capillary beds, at those postcapillary venules. Those venules will merge into veins, which will merge into larger veins, which will merge into the superior inferior vena cava and go to the heart. So those capillaries, they're all emptying into venules. Those venules, those specifically those postcapillary venules, they have an endothelium. They have some of those pericytes that help hold everything together, but they will allow fluid and white blood cells to travel in and out of those venules and into the tissues. Just like arterioles, we have larger venules and smaller venules, just like we have larger arterioles and smaller arterioles. So those larger venules could have 1 or 2 layers of smooth muscle cells, just depending on where they are in the circuit along heading back to the heart. So veins are what are formed when those venules come together. Veins have all 3 tunics or all 3 layers, but they're thinner cells. They have larger lumens than the arteries. The tunica media may be thin, but that tunica externa is thicker. Veins also are kind of storage vessels. Kind of a good way to put it. They're storage vessels. Because they hold, at any time, they can have up to 65% of our blood supply are in veins. Because they work differently than arteries to get blood around. So we're going to kind of look at how they work. But here's just kind of a comparison of what an artery versus a vein. An artery, usually they maintain their shape really well. Veins will maintain their shape when there's blood pushed through it. If not, they all kind of just collapse down otherwise. Just kind of depends, but you can see that outer layer of a vein here is a lot thicker than the other layers, which is different than an artery. An artery, that tunica media has a lot more to it than the veins do. So this kind of just shows where blood is in the body. So like 15% of it is in your arteries, 12% is in the pulmonary blood vessels, which are the blood vessels to the heart. 8% of your blood at any time is in your heart, 5% is in your capillaries, and 60% is in your veins. So most of the blood is in our veins at most of the time. Because our arteries is where blood is being pumped out of the heart into, it has a higher pressure. By the time the blood hits the veins, they've gone through arteries, arterioles, capillaries, venules, then we're back to veins. So in that process, the blood pressure has gotten very low. So our veins have adaptions to them to help get blood back to the heart. We have valves in our veins. If we have a vein here, we have some kind of valve that'll open and close as blood is being pumped through to help prevent that backflow. We have venous sinuses. Like that coronary sinus in the heart that drains into the heart. We have dural sinuses in the brain. We have a place where blood just kind of collects into before it gets shunted out somewhere else. So here's that picture again showing all the layers of the arteries compared to the veins. You can see how that tunica externa in this vein is so much thicker than in the artery. You can see in the artery how that tunica media is thicker than the tunica media in the vein. That tunica intima is about the same for both though. So here's a summary of those blood vessels again. So what are varicose veins? Varicose veins are when veins are dilated and painful because their valves aren't working. So those valves are supposed to prevent backflow, but they don't. So those valves are not, they're letting blood flow back through, back down, and so blood starts to kind of pool. Varicose veins could be caused from hereditary. They could be, your parents have them, you might have them. If you stand in one position. That's why if you're stand, you should move around every so often. Obesity. Pregnancy can cause varicose veins. And as I said, that's where blood pools. And it actually affects quite a few people. 15% of adults. That's kind of a lot. If you have too much pressure in your veins, it can actually cause varicose veins too. And what causes excess pressure in your veins? Trying to deliver a baby. Even trying to have a bowel movement can do that. And that can even cause hemorrhoids. There are veins in the anus that can engorge with blood, and that's what causes hemorrhoids. So we have different kinds of anastomosis around the body. We have vascular anastomosis, and that is kind of an interconnection of blood vessels. We have an arterial anastomosis, and that kind of gives blood other directions to flow. So like if you cut an artery open doing something, it's going to kind of block off that artery so blood flow goes somewhere else until that is fixed. But it makes sure that blood is continuously going where it needs to go. So we have anastomosis around joints. You have some really good ones around your knees. In your abdominal organs, you've got some anastomosis. You have some in your brain and in your heart. We have arteriovenous anastomosis, which are shunts and capillaries. There's a that's where when we were looking at that meta-arterial that takes the blood from the arterial to the venule without sending that blood through those capillaries. Where is it? This one. This here is that meta-arterial. That connects that arterial to that venule. So we have those kinds of anastomosis. And then we have venous anastomosis. We have a lot of them around the body. So it doesn't really occlude blood flow from anywhere. It lets blood flow back to the heart, whatever direction it is heading in, really. So let's look at how our circulation works. I've kind of been mentioning it a little bit as I've been going, but let's look into it some more. So let's first look at the flow, pressure, and resistance. Blood flow is considered the volume of blood flowing through a vessel, organ, or entire circulation in a given period. So doctors look at that. We'll look at blood flow. It's usually measured in milliliters per minute. And your blood flow is equal to your cardiac output. It's pretty consistent, but it also depends on organ need, organ level, what different organs need. Like if your intestines are trying to digest food, they may need more blood supply than if you're laying on the couch doing nothing. Your skeletal muscles don't really need a lot of blood supply. So our blood pressure is the force per unit area exerted on the wall of a blood vessel by blood. It's read in millimeters of mercury. And that's what we were kind of doing in lab on Tuesday. Was kind of playing with those blood pressure cuffs and seeing what kind of blood pressure what blood pressure people have. And it's that pressure gradient that pushes blood forward. And our resistance is our opposition to flow. So what could be causing blood to slow down its flow? Could be viscosity. How thick is the blood? How long is the blood vessel? How big around is that blood vessel? Those all determine resistance. Like we talked about a little bit, capillaries have a different resistance than the aorta because of the size, because of capillaries, only one blood cell can get through at a time versus the aorta, all the blood from that ventricle is getting pumped out at once. So as I kind of said, viscosity is how thick. It can also mean stickiness of blood because we've got platelets, we have white blood cells in there, not just red blood cells. So the thicker or the greater the viscosity, the harder it is to push that blood through those blood vessels. So if we have thicker blood, it's going to cause an increase in resistance. That total blood vessel length, that longer the blood vessel, the greater the resistance. That they may have a long ways to go. And of course, that diameter, how big is it? The larger it is, the less resistance. The smaller it is, the more resistance. And those blood vessels can constrict or get smaller. They can dilate and get bigger and change that resistance. But there can also be something like an accumulation of fatty plaques on the walls of blood vessels from atherosclerosis. That's going to increase resistance because it's almost going to create like a turbulence, like a turbulent flow through that blood vessel because the blood has to go around that fatty plaque and not get stuck on it. So if there's something in the way of that blood flow, like that fatty plaque, it's going to increase resistance again. So it's kind of like drinking a milkshake through a straw. It's a lot easier to get your milkshake out the bigger that straw is. The smaller that straw is, it's a lot harder. There's a lot more resistance than that bigger blood vessel or that bigger straw when you're trying to get a milkshake. So it's kind of a good way to compare it actually to the blood flowing through your body. So our systemic blood pressure. That systemic blood pressure is the heart pumping to generate that blood flow because it's pumping the blood from the ventricles to the aorta out to the body. So every time it pumps that blood, it's going to create a blood flow. It's going to create what we measure as blood pressure. That blood pressure is actually when the flow is opposed to resistance. So if it's saying what kind of resistance is found in those blood vessels. So as I've said multiple times, that pressure is highest in the aorta, and then it just continues to decline throughout the body. The further away from the heart, the lower it's going to be. So this kind of shows what the blood pressure is like in the aorta versus the arteries, arterioles, capillaries, venules, veins, all the way down to that vena cava that goes back to the heart. How much that blood pressure drops. And it drops pretty quick. As you can see with the arteries, this is why we're actually able to take blood pressure in the arteries because it'll give us a pretty accurate reading for what's going on in the heart. With the heart pumping it's the blood out because its arteries are still pretty consistent with the aorta for blood pressure. So of course our blood pressure is determined by the elasticity of arteries. That aorta is a very elastic artery. So the aorta is going to stretch every time blood is pumped out. And then we also have to look at the volume of the blood pumping out. Is there a lot of Is it a normal amount of blood? But what if you've lost a bunch of blood? What's going to happen to your blood pressure then? So, your blood pressure near your heart is what's called pulsatile. I know some people on Tuesday were saying that they could feel their heartbeat in their arm where blood pressure was being taken. That is exactly what it means when it is pulsatile, because you can feel it with each heartbeat. So as we were taking blood pressure, we were taking the systolic pressure and the diastolic pressure. That systolic pressure is ventricular contraction. That diastolic pressure is when the heart is at rest. We have a pulse pressure, which is the difference between systolic and diastolic. And then we take our pulse. Pulse is usually always taken at the doctor's office. When they take your blood pressure, they usually take the pulse too. That is that throbbing, that pressure through the arteries every time the heart pumps blood. So you can feel that. That's usually taken around the wrist. You can take it other places. There's other pressure points around the body where you can take the pulse. Just depends. So different ways to monitor how your blood pressure, your circulatory system is actually working. These are called vital signs. Anyone going into nursing, medical programs, MD, PA, OA, you're going to learn to do this with every patient because you're going to take their pulse. You're going to take blood pressure on every person. You're going to check their respiratory rate, how many breaths per minute. And you'll learn to check body temperature on every patient that walks in the door. The pulse that is most commonly used is the radial pulse, which is the one that's on this in your wrist on the side where your thumb is. You take that's a good place to take that pulse. That is that radial artery. But we also have pressure points. These are other places where arteries are very close to the surface. So if say you're really hot, you're overheating almost, these are places where you could put like an ice pack, something cool to help kind of cool the body off. It can also stop the flow of blood in case of hemorrhaging. So pressure points can do a lot of good. These are the main pressure points. You can actually feel the pulse at every one of these. If you have that temporal artery, you have a facial artery. Common carotid artery, that brachial artery, radial artery, femoral artery, popliteal, tibial artery, and then there's an artery on the top of your foot that's called dorsalis pedis. Those are all places where you can feel the pulse. When I was in school, we had to find every one of these. So depending on the program, you may as well. So we kind of talked about how to measure blood pressure. But we wrap that cuff around the arm above the elbow. You increase it in pressure until you block off that, you occlude or close off that blood supply to that brachial artery. Then you slowly release the pressure while you listen for these sounds of corticough. That is what you hear with the stethoscope when you put that stethoscope at the antecubital fossa or the front part of the elbow. Systolic pressure should be less than 120, and the diastolic should normally be less than 80. So you're listening when you first start hearing sounds, that's your systolic pressure. When you stop hearing sounds right at that point, that is the diastolic pressure. In the capillaries, pressure can go anywhere from 33 millimeters of mercury to 17 millimeters of mercury. We want low capillary pressure because those capillary walls are so small. If the pressure is too high, it could cause those capillaries to break. We don't want too much pressure because we want to be able to exchange fluids, like in the lungs, we want to exchange gases. So if the pressure is too high, it's going to cause problems. We want low pressure in those capillaries. So our venous blood pressure, it only changes a little bit here and there, but it's usually around 15 millimeters of mercury. So if you think about it, because the pressure is so low in veins, if a vein is cut, blood just kind of oozes out. If an artery is cut, blood spurts because the pressure is higher. So we want that low pressure in the veins. But that's also what requires us to have those valves in our veins to get blood flow to go back to the heart. So there's different ways that blood actually gets pushed back to the heart. This is why, if you've ever heard to get up and get your blood flowing, this is what this means. Your muscles will act as a pump and milk the blood in the veins back up to the heart. They push the blood through to the next valve, and then the muscles will continue to push the blood to the next valve after that. That is what it means when somebody says to go get your blood pumping, get your blood moving. You're using your muscles to push the blood back to the heart. We have a respiratory pump. So when we're breathing, pressures will change every time we take a breath. And that breathing actually moves blood towards the heart. Every time our lungs fill with air, it squeezes the veins in that abdominal and thoracic area because it's closing the space in that thoracic cage. We also use our sympathetic nervous system. We have sympathetic vasoconstriction or venoconstriction, sorry. So our smooth muscles constrict to push the blood back towards the heart. So there's different ways that blood will get places. Here is that muscular pump. Every time that muscles contract, they are pushing blood closer to the heart. And then these valves open every time that muscle contracts to push the blood up, and then the valve will close to prevent backflow. So our body does a really good job of kind of maintaining our blood pressure. It usually doesn't spike up and down all over the place like at any given second. I mean, if something were to happen to cause it, that's one thing. But if you're sitting doing nothing, or as we're doing right now, if you're sitting and listening to a lecture and maybe taking notes, your blood pressure is not going to be spiking all over the place. So your body does a really good job of maintaining it. Your body maintains the blood pressure with the heart, the blood vessels, and the kidneys all playing a role in it. Your brain supervises the whole thing. Make sure your body doesn't do something it shouldn't. So, cardiac output, how much blood is pumped out of the heart, your peripheral resistance, and blood volume. That all plays a role in blood pressure. So, there's different controls or different factors that control your blood pressure. There's short-term and long-term things that control blood pressure. Your neural controls, so your nervous system, that will control your blood pressure. Hormones can be a short-term regulator, but the long-term main regulator of your blood pressure, renal controls, or your kidneys. Your kidneys play the biggest role in maintaining that blood pressure. Our neural controls. Our main arterial pressure is maintained by altering blood vessel diameter. Like we've talked about, they can dilate, they can constrict. They'll do that to help maintain your blood pressure. So if your blood volume drops, you lose a lot of blood pretty quick. Your vessels are going to constrict. Your body's going to try to maintain your blood pressure, but it's not going to be very good at it, but it's going to try. Your body can, as I've kind of talked about, also alter where the blood is going. Like when you're exercising, you need more blood to go to your muscles. If you're digesting food, you need blood to go to your digestive tract. It all just kind of depends on where we need blood and when. So we have some different reflex arcs that help with regulating blood pressure. We have a place in our brain, in our medulla. We have the cardiovascular center of the medulla. That helps with regulating your blood pressure. We have baroreceptors chemoreceptors, and then we also have higher brain centers. So that cardiovascular center, sympathetic neurons in the medulla. We have in that cardiac center, we have cardioinhibitory and cardioacceleratory centers. So we inhibit things to slow down the blood pressure. We have acceleratory, they speed up the blood pressure. Those vasomotor centers, they'll send out information on those sympathetic efferents to blood vessels. They will constrict where needed. When a blood vessel constricts, it's called vasotone. So those baroreceptors, those are different nerves. Chemoreceptors are nerves. They're determining what's going on in that body to what needs to happen with blood pressure, anything else. Those baroreceptors. We have one in our carotid sinus, aortic arch, the walls of large arteries of the neck, and the thorax. So if our mean arterial pressure is high, what that does is we have increased blood pressure that'll stimulate those baroreceptors to increase the input to the vasomotor center. So we're sending information up to the brain. It inhibits the vasomotor and vasoacceleratory centers. It'll stimulate that cardioinhibitory to decrease blood pressure. So those baroreceptors are sending information to the brain, letting your brain know, hey, your blood pressure's too high. Slow it down. We can vasodilate. We can dilate our arteries, arterioles, and that'll slow things down. We can also have venodilation, and that puts more blood in the reserves. Remember, about 60% of our blood is sitting in the veins at any given time. And that'll decrease how much blood is coming back to the heart, and it'll decrease the cardiac output because blood isn't coming back as fast. And that also decreases cardiac output. So if less blood is coming to the heart is not going to be able to pump out blood with as much force because there's not as much blood in there. But that sympathetic activity can be inhibited through those baroreceptor reflexes, and it can stimulate that parasympathetic, that rest and digest, because that'll reduce our heart rate. And it decreases that blood pressure. But what happens if our mean arterial pressure is low? That happens. We have vasoconstriction is initiated. It increases cardiac output and blood pressure. We want to lower our blood pressure, we dilate. If we want to raise our blood pressure, we constrict, make things smaller. We have a carotid sinus reflex, and that monitors your blood pressure because we don't want too high of blood pressure going to the brain, but we don't want not enough blood going to the brain either. your blood pressure is too low, we may not be getting enough blood to the brain. That's why when people have really low blood pressure, they sometimes will pass out because they're not getting enough blood to the brain. We also have an aortic reflex that helps to maintain the blood pressure. Those baroreceptors are kind of not efficient or effective if we have some kind of altered blood pressure that is kind of maintained. Like our body kind of adapts to hypertension. So here's how our body tries to maintain homeostasis. That lovely trying to keep things evened out between too high of blood pressure versus too low of blood pressure. We have those different baroreceptors and how they're trying to kind of alter the vessel length width to help maintain blood pressure. Our chemoreceptors. We actually have chemoreceptors in our aortic arch, the arteries of your neck, and they'll detect increases in carbon dioxide, or if your pH gets too low, or if we don't have enough oxygen. These chemoreceptors are detecting the different chemicals in our blood, of course. These chemoreceptors can cause an increase in blood pressure because they can signal that cardioacceleratory center to increase their cardiac output. We want to increase our cardiac output to get more oxygen in our blood or to get our blood cleaned out through those kidneys or decrease that carbon dioxide in our blood. They can also signal the vasomotor center to increase vasoconstriction, which increases blood pressure through that way as well. So we have different reflexes that are found in the medulla of the brain, but our hypothalamus and cerebral cortex can also modify blood pressure. They send information to the medulla, and then the medulla will send information out to the blood vessels. When you're stressed, you can thank your hypothalamus for increasing your blood pressure. Your blood pressure. Your hypothalamus will also redistribute blood, like I've kind of talked about during exercise. Blood gets redistributed to the muscles. That hypothalamus will help with changes in body temperature. So it does that thermal regulation for when you're too hot or too cold. It'll help kind of take care of both of those. But we just finished with the endocrine system. Let's keep looking at hormones. Hormones are going to work with most of our systems from now on. So, your hormones play a role in blood pressure. Epinephrine and norepinephrine, of course, they're from your adrenal glands. They play a role in increasing carbon dioxide, and they can also vasoconstrict. Angiotensin II, they vasoconstrict. Antidiuretic hormone, if we have a high level of antidiuretic hormone in our system, they'll vasoconstrict. Atrial natriuretic peptide. This will decrease your blood pressure. because it'll cause a decrease in blood volume. So here's the different hormones, what they do to your blood pressure. They all pretty much raise your blood pressure except for atrial natriuretic peptide. That is the only one that will decrease your blood pressure. As we talked about, our kidneys are the long-term mechanism that regulates blood pressure. Those baroreceptors, they can adapt to change quickly and over a long term. If we have chronically high or chronically low blood pressure, they adapt to that. So we kind of alter the blood pressure through the kidneys by altering blood volume. We can, as the blood gets filtered in the kidneys, if we're releasing more water out, that can change blood pressure versus holding on to more water. That changes blood pressure. So they have a direct mechanism and an indirect mechanism that regulates blood pressure. Let's look at that direct mechanism. The direct renal mechanism, they alter blood volume without hormones. So independently of hormones means they don't use hormones to alter that blood volume. To increase the blood pressure or blood volume, if we have an increased blood pressure or we have a large volume of blood, we're going to excrete or eliminate urine. That will reduce blood pressure. But if we have a low blood pressure, we're going to conserve water because more blood volume, the higher your blood pressure is. The lower your blood volume is, the lower your blood pressure is. So here's our arterial pressure through direct renal mechanisms. Blood gets filtered by the kidney. We're creating less urine. Our blood volume increases because we're not getting rid of a lot of water. Or vice versa. Let's look at the renin-angiotensin-aldosterone mechanism. The renin-angiotensin-aldosterone mechanism will, if we have a decreased blood pressure in our arteries, our kidneys are going to release renin. That renin, of course, hormones get released and they get into the blood. And as renin is in the blood, it's gonna cause angiotensin to convert to angiotensin 1. It's going to use the enzyme angiotensin converting enzyme from the lungs to convert angiotensin 1 to angiotensin 2. Let's look at this for a minute, because that is that does get confusing. So if we have a decreased blood pressure, it's going to cause renin to be released from the kidneys. That renin gets into the bloodstream and it signals angiotensinogen to convert to angiotensin 1. At that point, that angiotensin 1 is going to go to the lungs where it is converted from angiotensin 1 to angiotensin 2. So that angiotensinogen, that first part happens in the liver. The second part happens in the lungs. Angiotensin 2 can work in 4 different ways. So it can stimulate aldosterone to be secreted. It can cause antidiuretic hormone release. It can trigger hypothalamic thirst, so we drink water. And it can also be a vasoconstrictor to increase blood pressure. So once we get that angiotensin 2, it can secrete aldosterone. Aldosterone increases the absorption of sodium from the kidneys. Angiotensin 2 can stimulate antidiuretic hormone release from the posterior pituitary. It can stimulate the thirst centers so you drink more water. Angiotensin 2 can also cause vasoconstriction. So the goal of the body is to keep your blood pressure at a rate that blood can be supplied to the body where it needs to go, but not too high to cause problems. So like I said, if blood pressure is too low, they may not be getting enough blood to the brain, which will cause somebody to pass out. But if blood pressure to the brain is too high, it could cause someone to have a stroke. So it's not good either way. So our body works pretty hard to try to maintain our blood pressure at a decent rate. So here is a nice flow chart that kind of goes through everything that can happen and how it changes or alters blood pressure, like an increase in activity that can cause venous return to go up, which increases stroke volume, which increases cardiac output. We can have a decrease of ANP. We can have fluid loss from a hemorrhage. If we have a fluid loss from a hemorrhage or excessive swelling, blood volume is down because we don't have blood to pump through. So our blood pressure goes down. So our baroreceptors actually work to stimulate the brain to try to increase the heart rate. You're dehydrated, your blood viscosity goes up. So you have an increased peripheral resistance. The larger you are, the bigger the body size, the longer the vessel length, which means you have more peripheral resistance. So there's a lot of factors that goes into blood pressure, maintaining blood pressure, keeping it somewhat steady. So let's look at some other ways that blood pressure is regulated or not. So every time, I know I said this to some people on Tuesday, Your blood pressure changes every time you change in posture. Physical exertion, even getting up and walking across the room. Emotional upset, stress, fever, all of that can change your blood pressure. Doesn't take much. Your age plays a role. Your sex, your weight, your race, your mood, and your posture. That can all change your blood pressure. Sometimes it doesn't take much to cause your blood pressure to just skyrocket. So hypertension, talked about it a little bit. Hypertension is this sustained, needs to be sustained. And I think I even mentioned it to some people on Tuesday. They don't diagnose hypertension on one time taking your blood pressure. It's usually over a series of at least 3 separate times you have an elevated blood pressure before they're going to diagnose you with hypertension, just because of a lot of those factors that were stated on the slide before can alter your blood pressure. So it's usually diagnosed over at the very least of 3 visits, just because they want to make sure that something didn't set you off that caused your blood pressure to go up. But you need a sustained pressure of 140 over 90 millimeters of mercury or higher to be diagnosed with hypertension. Pre-hypertension, if their values are elevated, so they're above that 120 over 60, but they're below that 140 over 90. That's pre-hypertension. Or it'd be 120 over 80. Sorry, not 60. 120 over 80. So it's above 120 over 80, but it's below 140 over 90. Because, as I've mentioned, it could be adaptations in the body because of fever, physical exertion, or emotional upset. That can cause, of course, your blood pressure to go up. Pre-hypertension is often persistent in obese people. So they have more areas to pump blood to. Their heart's pumping harder. They're usually above that 120 over 80, maybe just below that 140 over 90. So prolonged hypertension can actually cause some major problems. Heart failure, vascular disease, renal failure, even can cause a stroke because your heart has to work harder. And since your heart works harder, the myocardium layer in your heart gets bigger because the more the muscles work, the bigger they get. But your heart can also weaken and become flabby. And it accelerates atherosclerosis, or those fatty plaque buildups in blood vessels. So primary hypertension. Primary hypertension is 90% of hypertensive conditions. Because primary means there's no main cause for something. Secondary, if you see secondary in the name, that means that something else is causing that whatever problem to happen. But primary means there's nothing else that's causing it, other than hereditary, diet, obesity, age, diabetes, stress, smoking, etc. Primary hypertension is usually caused by some of those risk factors. They try to restrict fat, salt, and cholesterol from your diet. Doctors encourage exercise, losing weight. If you're smoking, stop smoking. They try all that stuff first before they move on to antihypertensive drugs. Because once you start those antihypertensive drugs, you're on them for the rest of your life. Unless you start exercising, you lose weight, or you stop smoking. That stuff can get you off those antihypertensive drugs. There we go. So my mom was on these antihypertensive drugs. She started exercising. She lost weight. She was able to get off of them. It is possible, but again, it's all about patient motivation. A lot of it has to do with patient motivation. A lot of people would rather pop a pill than go for a walk, sadly. As I said, secondary hypertension usually has some other cause that is causing that elevated blood pressure. So it's not as common, but something like kidney disease, endocrine disorders, like hyperthyroidism, they're getting a lot of thyroid hormone, that increases your blood pressure. It also creates massive anxiety, which really increases your blood pressure. But that's besides the point. Cushing's syndrome, renal arteries obstructed. Those are something else that is causing your blood pressure to go up. So if there's secondary hypertension, the treatment is to find and correct the underlying cause. If they can fix an underlying cause, that hypertension usually goes away. They treat the endocrine disorders. That high blood pressure will go away. If they treat that Cushing syndrome, that high blood pressure is going to go away. Hypotension, on the other hand, is when the blood pressure is below 90/60. It's not usually a problem unless you're not getting enough blood to the tissues, especially the brain. The nice thing is it's often associated with lifelong lack of cardiovascular illness. If you have a very low blood pressure, it pretty much will tell you that you're more likely than not going to have any heart problems in your life. There's different kinds of hypotension. Orthostatic hypotension. I get that all the time. It's when you go from like sitting to standing, your blood pressure drops, you get really dizzy, almost start sweating, feel like you're going to pass out. That's orthostatic hypotension. Chronic hypotension, it could be because of poor nutrition, Addison's disease. This is why I get orthostatic hypotension, is hypothyroidism. Causes your blood pressure to be lower. Acute hypotension, acute means it's an immediate onset, could be because of circulatory shock. Well, you lose a huge amount of blood, it's going to cause your blood pressure to drop drastically. And that's acute hypotension because your blood pressure just suddenly drops when you lose a lot of blood. So let's look at these. Circulatory shock. When we get circulatory shock, our blood vessels don't fill enough, so we don't get enough blood to the tissues. We have hypovolemic shock, large scale blood loss, vascular shock, extreme vasodilation. So we have a decreased peripheral resistance. Cardiogenic shock. That's when we have an inefficient heart that can't keep up with or can't keep an adequate circulation of blood through the system. So there's a lot of different kinds of shock. So when our blood flows throughout the body, especially when blood flows through capillaries, because that's where most exchanges between the blood vessels and the tissues happen. That is what is considered tissue perfusion, because we are exchanging oxygen with the tissues. We're removing wastes from cells. We're also delivering nutrients. In our lungs, we're exchanging carbon dioxide for oxygen. Digestive tract, I've talked about it. We absorb nutrients. Kidneys, that's where we form our urine. It's through those capillaries. So we need to control that rate of blood flow through that area to help make sure that we have enough time to do these things, to deliver oxygen, nutrients, to exchange gases, to absorb nutrients, to form urine. So we need to control all of that. We have extrinsic and intrinsic factors that control that. Our extrinsic controls would be our sympathetic nervous system and our hormones. So they can act on that smooth muscle in those blood vessels to constrict or dilate. Or they can completely, some of those capillaries, cut off blood flow completely, restricting blood flow to a specific area with those valves. We have intrinsic control, which is that autoregulation control of blood flow. And that's where it just depends on what the tissues need at the specific times. So again, when you're exercising, your muscles need more oxygen. So blood is going to be shunted more to the muscles. That's an intrinsic control. Your organs also can regulate blood flow to themselves, just depending on what they need, when they need it, and when they don't. That was the same thing as the previous slide. So here's a chart from your book. It even shows some page numbers from the textbook if you want to refer to them. For intrinsic and extrinsic factors. Extrinsic is usually from outside of that specific tissue and organ. Intrinsic is within that tissue or organ. Intrinsic is in, extrinsic, X is exterior or outside of. So as I've talked about this over and over again, blood gets redistributed during exercise. At rest, we're only sending about 20% of our blood to our muscles right now, unless you're walking on a treadmill or doing some form of exercise while you're listening to class. If you're just sitting, you're only getting about 20% of the blood supply to the muscles. But when you're exercising, your muscles can receive over 70% of your blood flow. And there's different intrinsic and extrinsic factors that affect that. Our intrinsic is those skeletal muscle arterioles dilate, so we get more blood flow to the area. Extrinsically, we're going to decrease blood flow to the other organs, like our kidneys or our digestive organs. We don't need to be creating urine if we're excreting wastes via sweat, because we can release water out that way as well. So this chart just kind of shows where blood is at rest versus when we're exercising. See how much of a jump it goes in skeletal muscles from sitting on the couch to playing basketball, what he's doing. But if you notice, the blood pressure, the blood flow to the brain does not change. It's always the same, no matter if you're sitting on the couch, running down the street, sleeping, your brain is always getting the same amount of blood. So we have our autoregulation, which is another intrinsic condition. We have reactive hyperemia. And that's where blood flow is increased to an area because of those intrinsic factors. We have metabolic controls and myogenic controls. Metabolic, well, that has to do with tissue metabolism. We need oxygen going to our tissues. We need specific ions and particles going to our tissues. So if we increase the metabolism or the metabolic activities to these tissues, that's going to cause a decline in oxygen. It's going to cause an increase in metabolic waste products. Not all waste, some wastes, but metabolic products in general. So what we can do is it'll cause the relaxation of arterioles and those precapillary sphincters. We can release nitric oxide, which is a vasodilator, to those endothelial cells. Endothelians is released from that endothelium, which is a vasoconstrictor. Nitric oxide and endothelians, they're usually pretty balanced. But if blood flow isn't going somewhere, it's not adequate enough for what our body needs, nitric oxide can take over control and vasodilate. Inflammatory chemicals like those found in mast cells that stimulates the inflammatory process, those cause vasodilation because we need different formed elements of our blood to travel to the area. What about our myogenic? Myo means muscle. Anytime you see myo, it is muscle. So we have myogenic responses, which has to do with smooth muscle. And how that smooth muscle can change that mean arterial pressure to keep that perfusion constant. We want to keep blood flowing to the tissues at the same rate. So we have what is called a passive stretch. So if we have an increased mean arterial pressure, that'll stretch the walls of the vessels, and that'll cause the smooth muscle to constrict. And it doesn't want to get stretched too much. It wants to control that blood flow to the area. But if we have a reduced stretch, that's going to cause that smooth muscle to dilate because we want to increase blood flow to that area. So it's all just if the blood vessel is stretching too much, they'll constrict. If it's not stretching it very much, they're going to dilate. That's all that means. So again, our long-term autoregulation. So if our short-term mechanisms don't meet the tissue requirements for nutrients from the blood supply, we have that long-term autoregulation, but it can take weeks to months to become effective. What we use is called angiogenesis. That's where new blood vessels form. So we increase the number of blood vessels to that area. The vessels that are already there will also enlarge. So if that, like on the heart, we were looking at the coronary artery on the heart. If that artery gets occluded or blocked, that can cause new blood vessels to form. That can cause other blood vessels to enlarge. Or people who live at high altitude. That can cause more blood vessels to form because they have an increase in blood. So they need a place to put it all. So here's just some of the different ways. We have the metabolic, the neural, the hormonal, intrinsic, and extrinsic controls on what they do to blood vessels in different areas of the body. So in our skeletal muscles, again, our blood flow is going to vary depending on whether you're active or not. When you're active, blood flow is going to increase to your skeletal muscles. Your skeletal muscles have a way to override that sympathetic vasoconstriction. That would happen as blood flow increases. Because if blood flow increases too much, that sympathetic nervous system comes in and constricts the blood vessels to try to slow the blood flow down to that area. But when you're exercising, they have a way around it so that blood can stay in that area when you're exercising. So if we're exercising, our muscles have a decrease in oxygen, increase in carbon dioxide, which causes vasodilation. And it overrides that sympathetic nervous system so we can increase blood flow to our muscles. Our brain. I pointed it out on that one slide earlier, but our brain averages about 750 milliliters of blood per minute. It has to be pretty constant because the neurons in your brain, if they're not getting the nutrients they need, they're not very tolerant to ischemia. Ischemia is where blood is not going to a specific area. So the brain has its own controls to make sure it's getting enough blood. They have metabolic controls. So if the pH is down, or we have a lot of carbon dioxide in that blood, the blood vessels in the brain will dilate. If we have a decreased mean arterial pressure, those blood vessels in the brain will dilate. If we have an increased mean arterial pressure, those vessels are going to constrict, just kind of like anywhere else in the body. But unlike the rest of the body, the brain is very vulnerable to change, like extreme pressure changes. So if that mean arterial pressure is below 60, That's when somebody faints. Syncope. But if that mean arterial pressure is above 160, it can cause cerebral edema, which is where fluid accumulates in the brain. So when blood can flows to different areas in the body. In our skin. Our skin needs a lot of nutrients to continually producing cells to produce the layers of our skin. So our skin, the blood flow is regulated based off of oxygen needs. Body temperature, but that's neurally controlled. Our blood actually, our skin provides a blood reservoir. About 15% of our blood sits in our skin at any time. Just kind of holds it. It's a nice reservoir. As I've kind of talked about, when our blood flow is determined by how hot or cold we are. There's a thermoregulatory system. So if we're hot, those blood vessels are going to dilate. And that's what makes you turn red. That's what causes you to start sweating, to release heat. I just said here, but if it's all related, your hypothalamus and your brain is what causes dilation, causes the blood to flush into those capillary beds and heat to radiate from your skin. That hypothalamus also controls when vessels constrict, when you're cold. If your cheeks ever get red in the cold, that's because vessels have constricted, but there was already blood in those vessels, so they're kind of stuck there. That's what causes your cheeks to turn red in the cold. Our lungs. That pathway is very short from the heart to the lungs, back to the heart. So those arteries and arterioles, they kind of act more like veins and venules. We don't need a very high pressure sending blood from the heart to the lungs because it's a very short distance. So in that pulmonary circuit, our blood pressure is right around 24/10 millimeters of mercury. That's very low because it's a very short distance. So we don't need it to go very fast. But if we have low oxygen levels in our blood, it'll cause those vessels to constrict. And that will cause blood to rush faster. High levels of oxygen will cause vasodilation. So if you remember with your blood pressure, the larger the vessels, the lower the blood pressure, the more constricted the blood vessels, the higher your blood pressure. Your heart. Your heart requires blood to be able to pump. It needs to pump blood to itself so that it can maintain pumping blood. So as we've looked at the heart, all those blood vessels on the heart, during ventricular systole, those coronary arteries are compressed so they don't get blood flow during that time. During that point, there is myoglobin that is stored. They supply the oxygen. During diastole, when blood is being pumped out of the aorta, it also gets pushed through that coronary circulation. So that coronary blood flow, blood going to the heart, is about 250 milliliters per minute. During strenuous exercise, those coronary vessels will dilate even more. So blood flow may be 3 or 4 times what it is at rest. Those cardiac cells actually use about 65% of the oxygen from the blood pumped through those blood vessels. Another 25% is used by other cells. So the only way to get more oxygen to the cells of the heart is to increase blood flow. That coronary blood flow, I should say. Capillary exchange. So the velocity of that flow in the blood will change as it gets down to the capillaries. It's the fastest out of the aorta. It'll go from the aorta to the arteries, to the arterioles, to the capillaries. Then that's where it slows down. It'll start to increase again in the veins. Capillaries have the largest surface area, or the largest area, so they're going to flow the slowest. But then again, it's only wide enough for a single red blood cell to get through at a time. So here's the capillary bed through here, and we kind of look at the velocity of blood flowing through the area at any given time. So you can kind of see during that capillary bed, even the velocity in the arterioles and venules, it slows down. So vasomotion is the intermittent flow of blood through capillaries. And that has to do with those precapillary sphincters, if they're open or closed, to allow blood to go through. And while in those capillaries, many molecules will diffuse between the blood and the tissues around it. In diffusion, things are moving down their concentration gradient. Because diffusion is not an active process, so it doesn't require ATP to complete. So there's different ways that molecules actually get through the capillaries. They can diffuse directly through. Respiratory gases, they can pass through clefts. So if there's water soluble solutes, they'll pass through a cleft. Fenestrations, those are those holes. Those are good ways to pass through. There's also active transport, which allows larger molecules as like proteins to get through blood vessels. Active transport takes something from one side of the cell to the other side of the cell. So here's this capillary. You can kind of see here the different ways things can move around into or out of these capillaries. So they can diffuse straight across. they can move through these intercellular clefts, this area through here. They can move through these fenestrations or those little holes, or they can use transport vesicles. Which those vesicles usually start on one side. They're filled with some whatever substance. The vesicle is transported across to the other side where it binds to the membrane.
Mommy, I'm in class.
Over there.
So it'll bind with the membrane on the other side where it will be released out. That's how transport vesicles will work. So fluid is usually goes through those clefts. So these little openings between cells. That's how fluid will usually get across. They kind of get forced out on the arterial side and they are returned on the venous side. So between that arterial side and the venule side, as it goes through the capillaries, everything kind of gets mixed together at that point. And that's how we maintain that interstitial environment around the blood vessels. So the cells, everything going on around the cells, all that is monitored because of that bulk flow where fluid is forced out in the arterial end and will return in that venous end. So let's look at the hydrostatic pressure that'll work with that bulk flow. That hydrostatic pressure is when a force is exerted by a fluid pressing against the wall. So we have a capillary hydrostatic pressure and an interstitial fluid hydrostatic pressure. That capillary hydrostatic pressure is where fluids get forced through that capillary wall. While that interstitial fluid hydrostatic pressure is when fluids are pushed back into the vessels. Capillary pushes out, interstitial fluid pushes it back in. Edema. I kind of talked about edema. It's an accumulation of fluid, but it's an increase in specifically interstitial fluid. So those capillary beds, it's either increased outward pressure, so more fluid is flowing out of the capillaries, or not enough fluid is coming back into the capillaries at the venule end. So an increase in capillary hydrostatic pressure causes more fluid loss from the blood, while an increase in interstitial fluid osmotic pressure can actually be from an inflammatory response. So when something's inflamed, that increases capillary permeability. It allows proteins to kind of leak into that interstitial fluid from the blood. It can cause fluids to be pulled into that interstitial space, so between the cells outside of the blood vessels. It can cause capillary colloid osmotic pressure, which is when we have a decrease, that's when that fluid doesn't go back to the blood. And that can actually be caused by hypoproteinemia. So we don't have enough plasma proteins, so we're not getting enough blood fluid coming back into the blood. Could be by malnutrition, liver disease, glomerulonephrosis, which is a problem in the kidneys. We'll go through that when we get to kidneys. But the difference between osmotic or osmosis and diffusion is the movement of particles. Osmosis is the movement of water. So when we're looking at osmotic pressure, it's the movement of water versus the movement of particles. Edema, so kind of talking about edema here, can be caused by, because not only does fluids get pushed back into the circulatory system, those venules through those capillaries, but fluid also gets drained from our system by the lymphatic system as well. So if our lymphatic system isn't working well, like something blocks our lymphatic flow, or you could have it surgically removed. Like if, especially in breast cancer that's metastasized to the lymph nodes, they'll remove those lymph nodes. So those have been surgically removed, which can block your lymphatic vessel flow. We can have what is called pitting edema. Pitting edema is if somebody has edema in a joint, you push your finger down in it and it holds, but once you pull your finger back out, it holds that same position that your finger was just in. That's pitting edema. That's when we have too much interstitial fluid in that subcutaneous tissue level. So it's above the muscles, but below the epidermis and the dermis. That's where that subcutaneous level is. If we have edema, our tissues won't work correctly. Things don't diffuse very well when trying to get nutrients to different areas of the body doesn't work well. Getting rid of wastes, that's really hard. It can be caused because of renal problems. A rapid onset of edema can actually affect our circulatory system because most of the fluid is lost from our circulatory system, and so we don't have as much blood to pump through things. So our vascular system, we have a pulmonary circulation, which we kind of talked about. That's from the heart to the lungs and back to the heart, and then the systemic, which is all the parts of the body and back to the heart. We kind of talked about it last week. This kind of goes through it again. How the blood goes from the heart to the lungs, back to the heart, pumped out to the body. This shows, we'll go into it more when we get to the respiratory system, how the pulmonary capillaries is where we have oxygen and carbon dioxide exchange. So there's some differences between arteries and veins. Arteries are usually deep, but veins can be both deep and superficial. I'm pretty sure I said that on Tuesday. Deep veins will share the same name with the artery, but superficial veins are the ones that have different names. Venous pathways are more interconnected. So there's more linking ways for blood to get back to the heart than one specific way, like an artery. And I know some of us looked at these on Tuesday. Veins can have more than one name, which is what makes that pathway hard to follow. Your brain and your digestive system have some pretty interesting venous drainage systems, which can be very confusing. The brain has a dural venous sinus, which collects blood before it gets pumped out of the brain. In your digestive system, we have a hepatic portal system, which actually goes through the liver before it goes to the heart. So it's getting cleaned in multiple places before it goes to the heart. So here's the systemic flow of everything from the brain to the heart and lungs to the digestive system and everything below. So as I talked about last week in lab, oxygen rich blood is in red, oxygen poor blood is in blue, except when we're talking about pulmonary. That pulmonary circuit is the opposite. So here's some tips for memorizing the different vessels. That should help for the practical on Tuesday. The name of the vessel usually reflects the body region, organ served, or bone followed. That is very true. So it's that body region, organ, or bone. Arteries and veins tend to run side by side, and they usually also run with a nerve. And our right and our left side are not always symmetrical. So with arteries and veins, that's kind of the fun part about doing some of this with cadavers. With the cadavers at school, the arteries and veins are very well dissected out, unfortunately. But it is kind of fun to see how every person's circulatory, all their arteries, veins, they're a little bit different where they go. So here's all the major arteries. I'm not going to go through this. If you want to take some time and do it, go for it. Here's listed all of them in the body. Here's all the arteries of the head and neck and brain. And no, you don't need to know all of these. You're lucky. So here's some pictures that show the different arteries going to the brain and the neck and the head. All the arteries of the brain. Some of the different arteries through the brain, how they all kind of work. Of the arm, of the abdomen. If some of these help you study, then perfect. If not, then they don't. Here's the leg. More of the leg. Now here's the venous circulation. So here's all the veins. Kind of put all of this in here just to kind of help. I'm not going to, I kind of went through all of these on Tuesday, so I'm not going to redo it. You're more than welcome to look at whatever you need. But here's all the veins through the arms, the abdomen, the lower limb. Okay, how are blood vessels develop? So the endothelial lining of blood vessels comes from mesodermal cells. And they kind of collect in bone islands. These bone islands will form vascular tubes. And these vascular tubes, through the help of vascular endothelial growth factor, another hormone, will determine whether we have an artery or a vein. Your heart already pumps by the 4th week of development. So most of the time before someone knows they're pregnant, the baby's heart is already pumping, sorry, beating. That's the word I was trying to say. Because the blood that is being pumped isn't useful to the body really, we have some fetal shunts. We have the foramen ovale and the ductus arteriosus. Because the lungs aren't functional, especially at 4 weeks. They're not functional until like week 24. But so we bypass the lungs. So as blood comes in that right side of the heart, I've really bad heart. You have the atrium, the ventricles, with the blood vessels coming in and out, just whatever. Blood, there's a shunt here that takes the blood from here, kind of push it that way. There's also another shunt here that you guys don't really need to know about. So blood that goes down here gets shunted there. Then between the pulmonary and that aorta that goes up and around, they kind of go behind each other and whatever. Where that ligamentum arteriosum is, here there's this ligament that kind of holds these together. That used to be a shunt. That shunted blood from that pulmonary circuit directly into the systemic circuit. We also have a ductus venus that bypasses the liver. Because we get our blood in utero from that umbilical vein and arteries from that placenta. Congenital vascular problems are pretty rare, but I mean, that vessel formation occurs to support the body growth. So as vessels form, as the baby continues to grow, it helps to support wound healing or rebuild vessels lost during menstrual cycles. So as we age, we can have problems with varicose veins, atherosclerosis, and increased blood pressure may happen. So our heart still gets subjected to aging just like everything else in the body does. So I made a list. I was going through it right before class started of different things for the test. There are 56 questions, and there'll be questions on how that autonomic nervous system will monitor and regulate heart rate. What exactly causes the heart sounds? So what's causing that lub-dub sound? What's happening during the different phases of that cardiac cycle? What is a hemorrhage? And what can cause a hemorrhage? What is the flow of blood through the heart and the body? What are the different layers of the heart? What are the hormones? Effect on the heart. How is cardiac muscle different from skeletal muscle? What is preload? How about those pacemaker cells? How do those pacemaker cells work? Like the chemistry behind them even. Because I know I went through some of that. Like potassium versus sodium. The different types of arteries. Atherosclerosis. What is it? What does it cause? Venous blood pressure. What is pulse pressure? Hypovolemic shock. How does our body regulate our blood pressure? What causes peripheral resistance? That pulmonary, can't spell it, circulation. Primary and secondary. Primary and secondary hypertension. I'm not asking with cerebral blood flow, like what arteries goes to what parts of the brain. Just like what is cerebral blood flow? How is it monitored? What does the body, how do we regulate it? Kind of stuff more than the arteries that go there, because that's a whole nother like 3 weeks of memorizing to get that down. And then those, how do those baroreceptors work? And that is just about, that's about like 98% of the information for the test there. So, and there's some other things, but you should know them from studying for the practical. So I didn't write it down. So if you study what you should be studying for the practical, then you should know it. Like, this lecture is part of the cardiovascular exam for next weekend. Yes. So it includes the heart and all the blood vessels. That's all that makes up all of our circulatory system. So you're welcome. And as long as you're studying what you should be studying for the practical, which is what's on those lists I gave you, then you'll be able to answer the few questions that I did not write down the information for on here. So kind of did a little bit of crossover with IDing of stuff, just try to make it a little easier with extra points if you study what you're supposed to study. So that is everything. I kind of didn't go over that whole, I really didn't go over that last section because we kind of went over it on Tuesday. So I didn't feel the need to sit and label out all the arteries and veins again for you, since we already did that 2 days ago. So if you have any questions, just let me know. Otherwise, y'all have a wonderful evening.
Thank you.
You're welcome. Good night.
Good night.
I have a question.
Of course.
So the test on Tuesday that we're going to be taking in lab is only on the sheep heart and the PAL images, and that's it, right?
There's the PowerPoint that I posted in Canvas that's labeled lab.
Okay.
That has the models pictures that'll be used.
Okay. And it's only on the lab, and then what you just went over just now is the test that's going to be next weekend.
Yes, for the lecture.
Okay, just making sure.
No problem. I understand.
Thank you.
You're welcome.
All right. Bye.
Bye-bye. Good night.
Good night.